Okay, good morning, everyone. I'm Prof. Raja Amin. Today is division of surgery, division of cardiothoracic surgery. It's turn to present our paper or our presentation today. I have Associate Professor Dr. Sivakumar Krishnasamy, who is one of our consultants, who will be speaking on complex thoracic oncology, pushing the boundaries of conventional surgery. So Siva has been with us for a while. He's also a student here, and he went overseas to the UK, learned thoracic and also cardiac surgery, and he's come back to us for a few years and has special interest in surgical oncology, and especially in the area of lung cancer. So without any further ado, I would like him to present his talk, and any questions can be posted as he goes along, and I will help him to moderate this. Siva, go ahead.
Thank you, Prof. Just a moment, I'm going to share my screen now. Okay. Can you all see the screen?
Yep, looks good.
Yeah, all right. Okay, good morning, everyone, and thank you to Faculty of Medicine for giving me this opportunity to share our humble experience on some of our complex thoracic oncology cases. So basically, the talk today is on complex thoracic oncology, pushing the boundaries of conventional surgeries. So a bit of outline, a little bit on anatomy of the thoracic cavity, what imaging technology and adjuncts we have in this time and date, oncology treatment, the MDTs we run currently at UMMC, what surgical treatments are there for complex surgical oncology, and live surgical case scenarios. So as you can see, the chest wall anatomy, it's pretty much standard with a cage, which is all covered mainly by bones. It's a fixed structure, and inside it, you have got the visceral component. So you've got the in the middle with the multiple ribs that are surrounding it, and of course the spine at the back, which basically covers the whole cavity. And you can see here the visceral component where you have got the heart, the lungs, and all the major vessels, which are basically protected by this cage. And any growth or any lesions in this cavity will take a long time before they can actually manifest with any symptoms. That's why majority of thoracic malignancies sometimes present to us at a very late stage, where sometimes resectability becomes questionable. So what do we have to help us decide in resectability? Mainly we have got low-dose CT scan, which are currently being used as in some centers as part of a screening module. High-resolution CT scans to decide mainly on surgical planes, PET scan to decide again on resectability, MRI, ultrasound, and also EBUS, which is an adjunct used for respiratory physician to stage the mediastinum. And in oncology treatment, we have got the neoadjuvant treatment, chemoradiotherapy, adjuvant treatment in post-resection cases where resection margins become questionable, the usage of both concomitant chemo and radiotherapy, and what is new and what's being running for the last 5 to 10 years has been targeted therapy, very much targeted for receptor sensitive, mainly seen in lung cancer, immunotherapy in a lot of newer treatment, and a lot of trials to support that, SABR and radiosurgery in certain cases of oligometastasis, which are combined with primary surgical resection. Now, the MDTs, what do we have basically? A once a fortnight meeting. We have it together with the chest team, radiology, oncology, and CTS team. Other teams are also invited when it is needed. We have got a lung cancer MDT once a fortnight between the chest, cardiothoracic, radiologists, and pathologists. And we do also have ad hoc MDTs whenever needed, when we get complex thoracic cases where we need to decide to operate or not to operate. Now, for the surgical treatment, there are various forms of treatment modalities that we offer. It can be in the form of VETs, uniportal, multiportal, and even open surgeries for major lung resection. We also do offer single, double sleeve resection. And these are all uncharted territories which over the years, the surgeons have gotten more comfortable and more familiar with the anatomy, and we have moved to providing this form of treatment. And we are getting a good midterm results with this, even in the Asian and Western data. In terms of thymectomies, we are also performing uniportal VATs, and these have benefited a lot in myasthenia gravis patient. And a lot of it has been supported by the New England Journal paper, which was out in 2015 for non-thymomatous thymomas, where they benefit the treatment of myasthenia gravis, complex mediastinal tumors with radical local resection, radical pleurectomies, chest wall resection, and reconstruction, diaphragm resection, which are all only possible with multi-interdisciplinary team management between plastic surgery, general surgical subspecialties like hepatobiliary team, vascular team, thoracic inlet surgery with the plastic team, and also the hand team, and of course tracheal surgery, open and also stenting. So I will continue my next talk with some few live cases we have done over the last few years, and also to share our experience and outcomes in these complex cases. We start off one with a very recently done case, was about a month and a half, 2 months ago, a 34-year-old lady from Johor, who actually presented with a large mass in the mediastinum, which came in incidentally when she actually presented with shortness of breath. She went on to get a chest X-ray and further had a CT scan done and a tissue diagnosis, which confirmed a stage 4 thymoma, where she presented with a pleural mass, effusion and invasion into the diaphragm, liver, and to the right atrium and SVC. She underwent 6 cycles of neoadjuvant chemotherapy. However, the lesion only showed a small reduction in size. We had an MDT. My oncology team was very much bent on for us to do surgery, although we on the surgical side did have our doubts, and they also did offer that if we could not get a R0 resection, even an R2 would be acceptable, and they would probably offer radiotherapy. The main reason they wanted us to go in was because they were concerned on the area of the heart where radiotherapy would be very difficult and challenging, and the load of the tumor was a lot. So this is her pre-op CT scan. You could see a large amount of tumor burden in the mediastinum, very close to the right atrium and also hilum, and also a large burden of the tumor on the diaphragm and the pleura. So we took her in. I did a right posterolateral thoracotomy, which we then extended into a thoracolaparotomy for the diaphragm side. And then we did a median sternotomy to remove the tumor over the SVC and right atrium. So this is the pleura with the nodules that was removed through the thoracotomy. And this is the thoracolaparotomy incision, where we had the tumor released from the liver capsule. And this is where I had the help of the hepatobiliary team, who came along and gave us a good hand to mobilize the liver. And the tumor was removed en bloc together with the diaphragm. This was the diaphragm being repaired after the resection. And this is the tumor that was removed from the chest and the abdomen component, where the diaphragm extension was seen over here with the pleura. And surprisingly, we had a macroscopic R0 clearance and also microscopic R0 clearance from the histology report, which came back as a thymoma B2. So this was the team that was involved on the resection on that day. Now, this is another case, which was a combined case done together with the PIT surgical team, plastic surgery, and the hand team. This was done somewhere in May this year. It was a 9-year-old girl who presented with Horner syndrome of the right eye. Chest X-ray done showed a very large tumor at the superior mediastinum, and we did a CT scan which showed a large thoracic inlet tumor, and we had multiple MDTs, and we decided to go for a hybrid approach, where a uniportal VATS together with an open surgical incision. So I decided to do a mobilization intrathoracically, and you can see the lesion that can be visualized at the superior mediastinum on the right side, and then followed by a incision over the supraclavicular region, extending right down to the upper part of the manubrium sternum. And the tumor was then dissected out freely from the brachial plexus, and the subclavian artery was very close to the first rib, as you can see here. and the lesion was removed en bloc with no neurological injury to the patient, and patient has done well till date. Another case was actually another incidental finding in a 28-year-old medical officer. So as you can see, majority of these cases come in incidental to us, where they do not present with any symptoms only unless they decided to do a chest X-ray, and that finds out a lesion in their chest cavity. So they went on to do a CT scan, which showed a thoracic inlet tumor, and the lesion was very close to the major vessels at the thoracic inlet. Again, this was a case combined done with the plastic team. But here on the CT scan, we noted a lot of major vessels that was close to it. So we decided to do a 3D printing, which came in hand for our planning. And we did a combined approach via a U-shaped flap over the lateral chest wall on the right side for a good vascular control and lateral thoracotomy to remove the lesion in whole, and the HP came back as schwannoma. So you can see here how 3D printing has helped us. And this was all done in recent times. And all these wouldn't have been possible without the current technology and facilities we have for us to resect lesions like this, which would have been deemed non-resectable in the past. And this is the tumor that was removed in total with minimal blood loss, and patient had no neurological injuries at all. Another case, a 56-year-old male diagnosed with myasthenia gravis. This patient had a locally advanced anterior mediastinal mass with invasion to the superior vena cava, innominate vein, and hilum of the right lung. This was a joint management together with the neurologist, where we have to optimize the myasthenia gravis treatment before the surgery itself, and that gave us a window to operate, where the patient had prior to this 1 month history of being ventilated in Ampang Hospital ICU due to myasthenia gravis crisis. After optimizing him, we took him on and we operated on him. Of course, it was a challenging surgery. We did a radical thymectomy, and you can see here the tumor invaded a fair bit amount of the superior vena cava, and that was resected and blocked with a lesion, and the cuff of the SVC was removed, and the SVC was patched with a pericardium, as you can see over here. And this was the tumor that was removed and blocked together with a small portion of the right upper lobe of the lung where it was locally invaded. Another case, another patient again with myasthenia gravis on medication who had 2 crises in the past. And we find that all these patients with myasthenia gravis, if we do a minimally invasive approach, they can be weaned off ventilator quickly, and it reduces the risk of crisis. And this patient did well from a uniportal VETS thymectomy, and post-surgery, after 1 year, the patient was weaned off from all treatment. Prior to surgery, the patient was on high-dose steroids and immunosuppressive drugs. So you can see this is the uniportal wound where the patient had a uniportal VETS thymectomy, and the whole thymus was removed through this small keyhole wound on the right side of the chest. And this was the thymoma that was removed from that similar patient. Another case, 56-year-old gentleman. This patient was referred to me in early 2017, we had a history of right popliteal fossa liposarcoma, where he had it 20 years ago. He presented with shortness of breath and noted to have a mass in the pericardium, which was biopsied and came back as liposarcoma. He underwent 20 fractions of neoadjuvant radiotherapy, and the repeated CT scan showed the mass regress in size. However, it was adhered to the left ventricle. So we went in for a right radical resection and block, and the patient has been disease-free over the last 3 years. And this case actually has been published in the 2019 European Journal under the case report section. So this was his CT scan and MRI before the radiotherapy, neoadjuvant radiotherapy, and the mass was very close to the left ventricle, as you can see here on the MRI, the mass and the proximity of it to the left ventricle, also close to the esophagus and descending thoracic aorta. This is the size of the mass after undergoing radiotherapy. Now, the resectability was only made possible with the radiotherapy, where the mass size gotten smaller, and you can see the mass being away from the esophagus and the aorta now. And I took him in on for a surgery where I went on to a left posterolateral thoracotomy, and you can see here the mass was shaved off the left ventricle, and this is the heart. This is the right lower lobe of the lung, and the whole pericardium over that area was removed and blocked together with the mass. And you can see here the tumor itself, and this raw area here was portion of the myocardium that was shaved, and fortunately there was not much bleeding encountered during this time, and we've got a R0 resection for the patient, and this was the area that was repaired with a mesh to close the defect on the mediastinal pleura. So the patient has been disease-free till now. It's going to be his 4th year with January this year, and his surveillance CT scan has always been showed he's been disease-free and he's been doing well for the last 4 years. Another case, a young boy which presented to us in 2018, 24 years old, with neurofibromatosis type 1 with kyphoscoliosis. He was being under the ortho spine team follow-up. He complained of 6 months of worsening shortness of breath. A chest X-ray done showed a very large mass in the right hemithorax. We proceeded with a CT thorax and PET scan, and we found that he had a malignant nerve sheath tumor. This surgery I had to do has a combined surgery with the neurosurgical team, and combining surgeries for complex lesions like this can only be made possible with a multidisciplinary team approach. Now, post-surgery, he has been able to breathe well and currently is under IKN follow-up for the last 2 years. And he had adjuvant radiotherapy after the surgery. So you can see how big this lesion is. And in the past, this would not have been possible if we did not have a multidisciplinary team approach to approach this case. And his whole trachea was pushed at the distal end. It was almost like a slit-like tube. This was the intraoperative view of the tumor. And the tumor has been removed in total and blocked. And the patient has been doing well for the last 2.5 years now since his surgery. Now, this is the last case I just want to share with you all. Well, we spoke about resectability, and we did a lot of almost impossible resectability, which would have been deemed not possible in the past. And now we talk about operability. Now, a high-risk 83 years old with COPD, with borderline lung reserve and ischemic heart disease, diagnosed with non-small cell lung cancer. After a good MDT and family conference with the patient, we thought the best option for him was to undergo surgery, as he was in early stage 1 lung cancer. So this gentleman underwent right upper lobe lobectomy through a uniportal VATS. He was discharged 3 days after surgery, and his analgesia he only took was Celebrex and PCM. This was his intraoperative wound through a uniportal VATS. We gave a good intercostal block for him, and this was his wound just after surgery. And this is the patient himself after the surgery on day 1. So you can see he can do a good spirometer, 2 balls going up, and of course, thank to our physiotherapy team also for the help. And our nursing team, who has been always up on ball with the physio and ambulation for all our patients. So in a nutshell, nothing is impossible. I mean, this is from a book which one of my trainers while I was in Shanghai Pulmonary, who gave it to me, where he said, when nothing is impossible, a good team effort between nursing, physiotherapists, and the doctors will allow the impossible to become possible. A strong MDT, a good intersurgical discipline working relationship is what is needed. A proper selection and planning for cases, especially when the resectability or operability of a case becomes questionable, will make the results better. And of course, with modern oncological treatment, there'll be more and more advanced thoracic malignancies that will be coming to our doorstep. And we have to offer surgical resection when it's deemed possible. With that, thank you.
Thank you, Siva. Thank you, Siva, for the nice presentation. Can you hear me?
Yeah, we can, Prof.
Okay. All right. I open the floor for questions. If you look at the bottom of your screen, you see the Q&A section. Preferably, please put your questions there. While waiting for the questions, just want to say a few words that you know, since we're doing a lot of more complex thoracic oncology nowadays, which brings hope for patients, and in the advent of immunotherapy, we're starting to see more challenging cases. Am I right, Siva? Maybe you can say a few words about that. What are we seeing nowadays, and what are we offering them?
Yeah, actually, with the advent of newer chemotherapy drugs, immunotherapies, and also trials, one of the latest ones, which was the Pacific trial using durvalumab, the lifespan of later stage lung cancers in stage 3 and late 2Bs are beginning to show survival benefit and also progression-free survival from the disease. And combination of surgery with treatment like this, of course, will prolong their survival and also their disease-free. And that's where more and more surgical techniques in terms of complexity of the surgery, like sleeve resection, either single or even double sleeve resection, has to be embarked by the surgeons, because in order for us to offer combined surgeries, centrally located tumors will then present as a challenge to us. Or basically oligometastasis lesions, single lesions in the brain or even in the liver, are beginning to show promising results when we combine them with neoadjuvant treatment and surgery. So these are all a new uncharted territories where we are having a lot of midterm results. Long-term are yet to be seen, but I think they are being quite promising. I mean, we have had a patient with right upper lobe lung cancer, 43 years old. We did a VETS, right lung volume lung reduction surgery in January 2017. He had radiosurgery for the brain. And until today, this gentleman is alive without any recurrent disease, been on annual CT scan follow-up, and is doing well. So this tells you that we are probably doing good for the patients. But again, we got to be very careful when we choose this group of patients to offer surgery. And I think an MDT decision is what that's needed whenever we offer surgery for these groups, because it comes in ethical approval, and are we actually doing the right thing for the patient or not?
Okay, thank you. If anything you come up from this meeting, the two things I would say is important here. We have to go more for MDTs, all right? MDTs is very important for us. And number two, for the surgeons, for all the surgeons in the audience will know, our principles in surgery is primum non nocere, which means first do no harm. So we really have to sit down with our MDT partners and decide what is best for the patient. So is there a question here from?
Yeah, there is a question from
Nasir.
Yeah, sorry, Nasir, I think. Okay, he's posted lung adenocarcinoma involving chest wall with N2 disease. Post neoadjuvant downstage to N1, is it considered for surgical resection? Yes, the answer is yes. In fact, there are enough trials to support this. Now, for chest wall involvement with N2, you also have to consider radiotherapy to the chest wall, depending on the patient's symptoms, if they've got chest wall pain. And if they're downstage to N1, you have to restage again the mediastinum with a mediastinoscope first. And if that comes back as negative and PET is negative, then you offer them a lobectomy combining with a chest wall resection and reconstruction. But if it is still N2 disease with chest wall involvement, with multi-station N2 disease, the answer is no. You still have to consider systemic therapy, because you're not going to give any survival benefit. In fact, you might cause the patient with more morbidity, especially once it is hitting the bone. Chances of systemic metastasis is very, very high.
Okay. Somehow I'm out of the Zoom. I don't know why, but in the main screen. Anyway, maybe Siva, you can look. Any further questions you have there?
Yeah, there's another one from Dr. Nadia. How do you decide resectability, especially in tumors which are adherent to great vessels and pericardium? Okay, that's a good question, Nadia. Now, that we very much look at the CT scan plane, and of course, we discuss with our radiology colleagues, seeing whether is there a a plane between the vessels and the tumor. And if there are situations of doubtfulness and still strongly surgery has been pushed, we still take the patient in. Of course, in the consent, we will have to tell the patient there is a possibility of open-close if it is invading any major vessels. However, if there's a small portion of the vessel involved, like you saw in the SVC, we can resect it safely and do a pericardial patch, even if it is involving major vessels like the aorta. And if it is deemed safe, we can even resect and put in an interposition graft if the patient is going to benefit from that resection. Pericardium has never been a problem, resecting pericardium. Only invasion into the heart and which part of the heart and how safe it is to remove that portion of the heart is the part that we will have to study the CT scan properly and decide. I wish we had images which can actually tell us, but unfortunately, we only look at a flat plane and looking at how much room we have to maneuver or play with that to decide on a potential resectability. But until now, I guess we do not have any, I would say, specific imaging to actually tell us that, oh, it's safe to go and remove and it's not invading. I don't think so there's any yet.
Okay. Any further questions? We have reached 9:02, so we are at the end of our talk. So I will just wait for a minute or maybe 30 seconds, I think. If there's no further questions, I think we should end there. We'll just wait for a short while. Anything else to say, Siva? Or anybody else?
No, I think I guess the key thing here, it's basically we all work in a team, which not only involve doctors, nurses, physiotherapists, even our whole MDT group, which compromises everyone, including the radiologists, pathologists, and the referring teams from CHES, Oncology, and even the general surgical subspecialties. So whenever a case that comes by, although it might be deemed as a stage 4, and looking at the current flavor that we have now, stage 4 is no more deemed as the end of life. And if it is safe for resection in certain subtype of cancers, I think we should bring it forward to the MDT first before deeming the patient for palliative care or even palliative chemoradiotherapy. And I think that is the way forward. And right now for thoracic malignancies, we have a good MDT group where we sit down and discuss all cases. And if anyone come across any metastatic lesions or even any advanced thoracic lesions, bring forward to the MDT. And from the MDT, we will decide whether what will be the best course of treatment, whether it's surgery or not. I think we will decide that in the MDT itself.
Okay, thank you, Siva. I think with that, there's no further questions I see. So before we end, I would just like to say that, the cardiothoracic surgeons nowadays are much more approachable than before. And we work in the MDT team. So you can approach any one of us, the 3 consultants here, but you can approach any one of us, or Siva has special interest in thoracic oncology, and you can approach any of the MDT team members, and don't give up hope on all these patients. With the advent of, like I mentioned earlier, immunotherapy and the more aggressive approach by our oncologists, patients seem to be getting better. Better outcome for them, improve outcome with them with the advent of 3D printing and things like that with the new advances. It seems like they're more light at the end of the tunnel. So with that, I thank Professor Siva for his presentation, and I think we end it here for today. So a good day and have a safe MCO. Bye, everyone.
Thank you, Prof. All right. Thank you, everyone.